is Diagnosis Glaucoma with your hosts, Dr. Mona Colleen
and Dr. Harry Quigley.
Well, welcome to Diagnosis Glaucoma podcast. Today we have a member of the Wilmer Institute faculty, Dr. Bryce Chiang, who's not only an ophthalmologist and glaucoma specialist, but he's an engineer as well and has been studying glaucoma from that point of view. Bryce, you want to tell everybody a little bit about you and your present situation?
Sure. Thanks for having me, Dr. Quigley. Again, my name is Bryce. I am from Baltimore, actually, originally. Did my undergrad at Hopkins studying biomedical engineering. Then I went down to Atlanta to study at the Emory Georgia Tech MD PhD. There I was studying drug delivery to the eye, specifically looking at delivering drugs into the suprachoroidal space, which is a potential space found within the eye. Because of that interest in ophthalmology, I decided to jump coasts and go to Stanford for ophthalmology residency and then stayed there also for glaucoma fellowship. And then I've recently joined the faculty at Wilmer here and am finally excited to start, thinking about research questions and also helping to take care of glaucoma patients.
So what does engineering and biomechanics have to do with glaucoma for the lay audience that's listening?
Sure. So there's actually, I guess, a lot of engineering that can go into medicine in general. So, some of the things that we learned and also that I've studied, for example, a lot of intraocular pressure or eye pressure has to do with flow of fluid within the eyes. And this can deal with, all of the learnings that we learn with chemical engineering, with the retinal ganglion cell axons. They have to transmit information across the length of their axons, and electrical engineering has a lot to play with that role too. Whereas we're now talking about the biomechanics of the eye and how mechanical engineering can help play a role in that. And this all stems from, the thought that there are biomechanical changes at the optic nerve head, and these might be either beneficial or detrimental to the disease that we know of as glaucoma.
So glaucoma damage, the reason why eyes lose vision, is happening at this thing called the optic nerve head, where these nerve fibers leave the back of the eye. What's the relationship between the eye pressure and that particular spot, the nerve head?
Right. So glaucoma damage happens in a particular pattern, especially when we test with visual fields. These show up as arcuate patterns, which, kind of go around the eye. And if we try to localize the disease, we see that, for example, damage to the visual field doesn't really cross the midline. And the only way that this can occur is if the damage is at the optic nerve head, where the retinal ganglion cell axons, again, the cells that are transmitting the information to the brain, come into the optic nerve head. And if something happens focally along a segment of the optic nerve head, then you would end up with a arcuate defect on a visual field.
So the damage goes from that nerve head thing back to where these nerve cells live inside the eye. And when they are injured on that axon, they can die. And that's what causes vision loss in glaucoma. So it's this pressure thing. And pressure, of course, can be measured in a variety of ways. We measure it with tonometry. The average patient knows that we do that in every eye visit. But maybe some eyes are more likely to get damaged than others. And one of the things that's been said a lot is that aging causes the eye to get stiffer in most of us. So do you think stiffer is why glaucoma happens? Or why, if so, why doesn't everybody get glaucoma since everybody gets stiffer?
The stiffness can definitely change as we age. This happens, with the sclera, which supports the structure of the eye, also with blood vessels, and, everywhere else within the body. Some of this has to do with the changes in the extracellular matrix of the human body as we age. For example, there's loss of elastin around the 50, 60, 70 years old. But we do know that, as we grow older, the eyes become a little bit stiffer. And furthermore, in glaucoma eyes, they're even stiffer than their age-matched controls. The short answer is that of course, everything is really complicated. We have some people that have stiffer eyes that are getting glaucoma. It's unclear if this is if the damage is occurring because of the stiffness, or is it a compensatory mechanism to try to counteract the stiffness where the eye is trying to reduce the damage. The same thing with the eye pressure, where, the eye pressure is not the end all and be all with glaucoma. We have patients that have high eye pressure that never get glaucoma, patients with normal pressures that do get glaucoma. So there's a lot of complexity in understanding this problem, and I think that's part of the reason why the cause of glaucoma is still not really understood well.
One of the things that our work and your work, because we're working together, as the audience probably can guess by now, one of the things that we've noticed is that it isn't the baseline stiffness that's what the issue is, but how the eye responds and remodels itself. And if the tissues there are remodeling in a beneficial way, then somebody would probably not get glaucoma from a high eye pressure. And if there's remodeling going on even at normal pressure that's detrimental, then people can lose vision. So if you were going to envision a treatment that might affect this remodeling process, what kinds of things would you do and where would you deliver them?
So I think, again, my research background was all in drug delivery to the eye. And for me, the important word was the delivery part, and trying to figure out where exactly drugs need to go. So, upon coming to Wilmer, I thought working with Dr. Quigley would be great to try to better understand how and where to deliver some of these treatments might be. As we've talked about, maybe there is a beneficial effect of trying to modulate the stiffness of the tissue, and that would mean trying to change the extracellular matrix of the sclera, for example, or of the optic nerve head. And of course, this could be done in a targeted way, or it can be done for the entire eye. And obviously, those could result in very different, either causing worsening glaucoma or be beneficial for glaucoma, or it could be doing nothing. And I think that's part of the difficulty, is first trying to understand how these treatments might actually impact the biomechanics of the eye, and then further take that a little bit further and understand how the treatments can actually affect the neuronal function, and also see if they are actually neuroprotective in protecting the retinal ganglion cell axons.
So are these things that you start out with on human patients with glaucoma, these new treatments, or do you have some way of testing this in a laboratory?
Right. So, of course, we want to only do things that are helpful for our patients, or potentially helpful for our patients. So we want to try to start, with as basic, proof of principle as possible. For our work, we're going to be starting with pig eyes, which are reasonably similar to human eyes. They have a collagenous lamina cribrosa, which is the support structure for the optic nerve head. And they're about reasonable size compared to human eyes also. So we are able to obtain these pig eyes from slaughterhouses, and then we're able to test the eyes with different treatment methods and see how the eyes behave with each of these treatments. With Dr. Quigley's advances in his labs, we're able to see the axonal transport function in ex vivo eyes. So we're able to then also eventually see if there is a correlation between the biomechanical changes that we've done, and then also see if there's any changes in the axonal transport ex vivo.
So if I get it, well, first we have to say that everything's better with bacon. So I'm glad that we're working in pig eyes. But essentially, you're able to duplicate the short-term damaging effects of the eye pressure in pig eyes that come from the abattoir. So we can get large numbers of these and use them at relatively low cost. And of course, the animal was going to be sacrificed anyway for food purposes. So we're hoping that this kind of an approach will tell us a lot. Can you actually test drugs on the pig eye that's on a lab bench?
Yeah, so the benefits of being on the lab bench is it helps us, we can reach different regions of the eye to target different areas of the sclera and the optic nerve head to potentially either stiffen or soften the tissue in those regions and then see how the eye ultimately behaves. The difficulty in trying to deliver to each of these regions might be a little bit more complicated once the animal is whole or in a human, for example. And that'll be kind of the next step of the project is once we identify a treatment pattern that we think is promising to then try to extend that into a delivery system that could be done in a living animal.
So if you're going to measure something after you've delivered a drug or an agent to these pig eyes, what is it you measure and what instrument do you use to measure stuff?
Yeah, so the measurement techniques are quite complicated at the moment. They involve taking a bunch of pictures, and this is work done in collaboration with Dr. Vicky Nguyen, who is also on faculty in Johns Hopkins, but in the mechanical engineering department. We're able to take pictures of the eye. This could be with optical coherence tomography, which is used in the clinic now to take pictures in all of our patients, and then also could be with ultrasound or any other method, including confocal microscopy and also laser scanning microscopy.
So are any of these things could actually then be done in humans to see if your treatment changed the stiffness or the mechanics of the human eye? Which of those instruments are available to do that?
Yeah, so great that you asked, Dr. Quigley, because you're actually pioneering some of this work. The optical coherence tomography machine is currently used in the clinic and is used regularly on patients. Dr. Quigley and Dr. Nguyen are actually studying are able to take pictures in glaucoma patients and look and analyze the pictures to see how the tissue is responding to changes in eye pressure. Dr. Quigley and Dr. Nguyen, again, have done recent studies looking at the effects of surgery in lowering the eye pressure and seeing how the eye behaves. And then they're now looking at the effect of eye drops and possible laser procedures also.
So if you were going to develop something that changed the white part of the eye, the sclera, and we're now calling this overall area neuroprotection, meaning to protect the nerves that would die in glaucoma. This one would be called scleral neuroprotection. And if you've got something that we could then deliver to human eyes, we'd be able to measure it with this optical coherence tomography and see, are we changing this person in a beneficial direction based on the work that is being done in the lab. So that's kind of the trajectory that you and I see of this kind of work going on. Do you envision that this will be an eye drop? Glaucoma patients are all used to taking eye drops to lower their pressure. Could any of these drugs that you're delivering actually be delivered as an eye drop, or is there something better than that in terms of how to treat someone?
I think that's a really complicated question to answer. There's lots of people
That's why I asked you.
There's lots of people working on, better eye drop formulations. Dr. Ensign, who's also a faculty at Wilmer in the research divisions, she's looking at eye drops that are able to penetrate deep into the eye. It's always been I guess, commonly held belief that eye drops don't penetrate into the eye and, are basically going only as far as the anterior chamber, which is the front part of the eye in front of the iris, or maybe just a little bit behind. But some of that work, might be, some of the work that she's working on might be able to deliver drugs deeper into the eye, to the retina. So some of these technologies might be able to be used to deliver drugs in a pattern that we'd like to the sclera. Now, the patterning that we might want to try to achieve would be a little bit difficult. There's been plenty of groups that have tried to use laser light or light in general to try to pattern a extracellular matrix modulation technique. Riboflavin and ultraviolet light are currently used in corneal cross-linking, which is used to treat keratoconus, which is a disease of the front of the eye. And some groups have used similar techniques to try to pattern the treatments onto the back of the sclera. These can be, sometimes challenging to do, and also trying to figure out the exact parameters that need to be done, and also could also be toxic to the eye. So there still needs to be a lot of work in trying to figure out the exact delivery mechanisms. There is also the potential for trying to develop new drug delivery systems. For example, I've worked on trying to develop a drug delivery system that goes through the suprachoroidal space again, which is a potential space found between the white of the eye and the sclera, and also the choroid, which is the major blood vessel network within the eye. This space goes all the way around the eye to the back of the eye and stops right near the optic nerve head. So it might be a reasonable way to deliver drugs into and around the optic nerve head. And using a catheter, you might be able to pattern a specific way that you want to try to apply the treatment. So long story short, there's still a lot to try to figure out.
But I think very promising for glaucoma patients that we're working on treatments, not just to lower eye pressure, but in a whole new area of neuroprotection. Dr. Chiang, thanks so very much for being part of our podcast system. For those listening, be sure you check out all the other now 4 dozen podcasts in diagnosisglaucoma.com. The book for patients, Glaucoma, What Every Patient Should Know, is available there, both in written form and also in an audio version. Thanks very much.
Thanks for having me.
Thank you for joining us. Until next time, your mom says take your drops.